The next topic that we are going to go through is diabetic foot ulcers. And diabetic foot ulcers is an unfortunate thing that is happening. It has been referred to as one of the biggest problems we have nowadays. That is because diabetes is referred to as the silent epidemic. It is one of the biggest problems that we have here, where we have so many people. We have up to 1 in 10 people living nowadays with diabetes. One of the biggest problems that we have, however, is that the excessive amount of diabetics we have in the world, most of them don't even know. It is suggested that 1 in 2 will not know that they are diabetic until it is too late, because problems ensue. And one of the biggest problems that we have in diabetes is that these patients, up to around 600 million adults with diabetes, we have diabetic foot ulcers, which is one of the most common and severe complications in these patients, because 25% of patients living with diabetes will potentially develop a foot ulcer. Most of these ulcers become infected. Once they become infected, they become a lot more difficult to handle, and it is actually suggested that every 1.2 seconds somewhere in the world a patient will develop a diabetic foot ulcer. Worryingly enough, other statistics suggest that every 20 seconds there's somebody who has an amputation in direct relation to diabetes. What worries us about this is that some few years ago we used to say that this was every 30 seconds, and there are also publications suggesting now that it is actually less than every 20 seconds. The biggest worry for me in these statistics is that 85% of these amputations can actually be prevented. Prevention goes hand in hand with awareness, hand in hand with education. And when we're talking about awareness and education, we're not just talking about our patients, we're talking about healthcare professionals as well. So if we had to give a definition to what a diabetic foot ulcer is, it's the destruction of the skin and underlying tissues in the foot, usually accompanied by neuropathy and or peripheral arterial disease in the lower extremities. If we had to talk again about statistics, one of the worrying statistics that we have is the mortality rates. Patients with diabetic foot ulcers have a 5-year mortality rate which is even worse than some of the cancers. But while there's awareness, for example, a lot of awareness, thank goodness, about breast cancer, many people, if you talk to them about neuroischemic diabetic foot ulcers, they don't know what you are talking about. And that is why nowadays we have publications, for example, from David Armstrong, who is talking about that our patients are in remission. They should be taken care of and given as much importance as patients with cancer. There are quite a few different suggestions for standards of care all over the world, but usually they always talk about the same systems that we need to implement, talking about ischemia and restoration of blood back to the lower limb by means of revascularization, control of infection, offloading, management of the comorbidities, management of the diabetes itself, the wound care, and one of the most important things that we are talking a lot about today is time of referrals, because one of the biggest issues why most of these amputations are preventable is timely referral. The earlier we see the patients, the better we can take care of them. For example, if we look at the suggestions by the International Diabetes Federation, they suggest that any diabetic patient, even if they have had no problems before, still need to be seen at least once a year in a diabetic foot center. This makes sure that the patients are being followed up and prevention is being maintained. If they had more risk, so we have 3 risk categories, in the IDF they need to be seen more quickly. Another publication that came out more recently is the fast track pathway that came out from Marco Meloni and his colleagues, which gave us a template which is also included in your activity book about the referral system of these patients and how to manage diabetic foot ulcers in a systematic manner. What we know from the publications from Marco Meloni, but also from other people, is that the fast track pathways will save patients' lives. What we know that when there is a late referral, the wounds are more complicated, ulcers appear more often, and unfortunately amputations happen more often as well. When a fast track pathway is included in our facility to help our patients, we are ensured that there is better healing for the ulcers and there are less both minor major amputations as well as mortality. What is important to remember is our diabetic foot patients are VIPs. What do we mean here? V alludes to vascular, so looking at the ischemia, making sure that there is enough circulation going to the wound and to the lower extremity. I refers to infection and biofilm and inflammation that we talked about previously when we were talking about the wound bed preparation. P alludes to pressure offloading, and S looking at the sensation. And we'll go through all of these in more details. If you look at the causes of pressure injuries, we talked about this during the definition. We said that they are in direct relation with neuropathy and ischemia. The statistics suggest nowadays that neuropathic foot ulcers are about 35% of our wounds, while neuroischemic DFUs are 50% or sometimes even more, and the smaller number, which is about 10 to 15%, is ischemic diabetic foot ulcers. If it comes to classification, one of the things that we need to look at is looking at the guidelines that come out from the IWGDF. These guidelines come out every 4 years after very stringent systematic reviews, and they suggest that we use specific classifications in specific instances. They say that the 3 most recommended classification tools that we should use are the ones by the IWGDF itself, the SIMBAT classification system, and the Wi-Fi classification system. Other classification systems are considered old now. For example, one widely used is the Wagner. However, if you look at the IWGDF, they suggest that we use these 3 classifications. If we want to do a simplified foot exam, we need to look at 4 important things. The first one is vascular impairment. The second would be looking at neuropathy. The third includes looking at the foot to see if there are any deformities, and footwear are part of the foot when it comes to diabetic patients. So let's go one by one. The first one is peripheral arterial disease, where, like any other patients, diabetics can have ischemia in their lower ribs. However, the degenerative disease of diabetes has an impact on their circulation as well. They can still have microangiopathy and macroangiopathy. However, they can also suffer from arterial calcification. One of the easiest ways how to look at if the patients have got circulation is by palpating pulses, and the 2 most common pulses that we look at the foot are the dorsalis pedis as well as the posterior tibial. However, even if we manage to palpate these 2 arteries and find the pulses, it means that the macroangiopathy is not there. However, microangiopathy should still be ruled out. And this is why this is the initial assessment only. If we need to do further assessments, then we need to refer to the vascular unit to do more investigations that can be either invasive or non-invasive. When we are talking about neuropathy, neuropathy refers to the damage of the nerves. Again, the degenerative disease of diabetes will affect the nerves. The neuropathy will not just affect the lower limb, but obviously for today we're going to concentrate on neuropathy of the foot. The first type of neuropathy that we will talk about is sensory neuropathy. So we have the sensory nerves which give us the protective sensation. If we walk on anything on the floor when we are barefoot, we immediately feel it. In these patients, because their nerves are damaged, they can walk on a piece of glass and they won't even feel it. It is very difficult to explain this to the patients, because how can you explain to them that even if they walk on fire, they might not even feel it? The problem here is these patients start getting minor traumas without even realizing, and that will end up in an ulcer, that will end up in further complications. This is why it is important to give good education to these patients that they should not walk barefoot at any time. I know that in many cultures we suggest that we don't wear shoes inside. The solution to that is that you use a pair of shoes which are used only for the inside of the house. However, it is of extreme importance to make sure that these patients don't walk barefoot, because if they walk on anything, that can become an ulcer. The other nerves that can be damaged are the motor nerves, and the motor nerves control muscle movement. So when we have problems with motor neuropathy, there is weakness in the muscles, the gait of the patient is not correct, it ends up with certain parts of the foot which get extra pressure, and this will lead to complications like callus formation or even Charcot foot that we'll explain in a few minutes. This pressure, which is on areas where pressure should not be, will harden the skin of the foot, hyperkeratosis. It will end up as a callus. That callus can cause pressure on the skin, occludes the circulation, and it will end up as an ulcer. One of the less known is autonomic neuropathy. So the autonomic nerves control the function of the sebaceous glands in the foot, and therefore when there is damage to these nerves, the foot of the patients become very dry. It starts cracking, starts creating minor fissures where microorganisms can easily now go inside the skin and cause an infection. So how do we assess? Let's start with the first one, which is sensory neuropathy. Sensory neuropathy can be assessed in different ways. Probably one of the most common ways how to do that is by using the 10-gram monofilament, which is a strand of nylon. You press it on certain areas of the foot, and the patient has to tell you if they can feel the pressure, yes or no. We can also use a 128 megahertz vibrating tuning fork to do the vibration test. It is actually suggested that using the vibration test is more sensitive than the monofilament. It is definitely less expensive because you can reuse for a long time this tuning fork. You can also do heat and cold tests, but what is a very interesting new type of test is called the Ipswich touch test. This is very interesting because this is part of the patient empowerment that we have been talking about previously, because it's a very easy test to do. You don't need any equipment, you just touch the patient's toes, 3 of them on one side and 3 of them on the other side, lighter than a feather, less than a second. And the patient tells you if it is on the left foot or the right foot. This is great because the patients can do this test at home. You teach the wife, the daughter, or whoever it is to do the test for the patient. The Third thing that we said we need to look about is deformities. We are talking about hammer toes, claw toes, mallet toes, bunions, things that can be even found in everybody. It's not just the diabetic patients. However, the risk of these deformities for diabetic patients is that when they have these deformities, these become pressure points. When they are wearing shoes, it can rub on these pressure points and cause a small ulcer that can give us big headaches. The options here: one, get them surgically corrected. There are different types of surgeries that can be done to correct these conditions. If not possible for anything or other, then at least you have to make sure that the patients are wearing proper shoes that don't cause pressure on these areas, and you can use also gel pads that cover these areas that provide some cushioning that will decrease that pressure and friction on those areas. One unfortunately common feature in diabetic patients is Charcot foot. A Charcot foot is basically defined as a fracture. It can happen anywhere on the lower foot, but most commonly on the arch. A Charcot foot happens because either there is trauma the patient doesn't recognize because they have sensory neuropathy, or they can also have motor neuropathy, which gives that excessive pressure on the area because, again, of the degenerative disease which diabetes is. The bones are also more fragile and therefore more prone to fractures. One of the unfortunate things about Charcot foot is that in the acute early stages, the signs and symptoms of a Charcot foot is reddening of the skin and a slight increase in temperature, and this is usually misdiagnosed as cellulitis. So when we have any patient who comes to us who is a diabetic and presents with the slightly elevated temperature in the foot and there is redness in the foot, we have to make sure that we send the patient for radiology, making sure that we rule out if there is even the most minute fracture there. If there is any fracture, this has to be managed and the foot has to go into a total contact cast. The fourth part that we talked about was the shoes of the patients. One of the first things that we need to look at is, are these shoes safe? We have to inspect the inside of the shoes to make sure that there are no foreign materials inside the shoes. Look also at the bottom of the shoe. If you look at your own shoes, you might find that there is wear and tear which is similar from the left foot to the right foot. With patients with motor neuropathy, they have wear and tear on the soles of the foot where usually you don't find it, and this is usually dissimilar from the left to the right. Make sure that the shoes that the patients are wearing are safe. Obviously no stilettos, no pointed shoes, definitely no flip-flops which even cause damage between the toes, and open-ended sandals are not recommended, especially if the patient has sensory neuropathy. It doesn't mean that every patient needs to have special shoes. You can have shoes which are safe but are not only specific for diabetic patients, and nowadays, as we'll see later on, we also implement use of insoles for patients to create offloading. How can we do this examination? There are different types of ways how to do it. The very easy way how to do it, and again it is included in your activity book, is the 60-second foot exam that was presented to us by in-law from Canada. This does not replace the level of viewing of patients at least once a year in the Diabetic Foot Center. However, if we are doing the 60-second foot exam, so basically it takes about 3 minutes to do both legs, is a very good predictive tool to make sure that our patients are being seen and, if need be, to be referred further on if there is increased risk of problems. One of the parts of the standard of care which is very important in the management of an active diabetic foot ulcer, or if there is excessive pressure, or if there is Charcot foot, is offloading. So when we use offloading for our patient, it means that we are reducing, redistributing, and removing detrimental forces which are applied to certain areas of the foot. We alleviate the pressure of high vertical and shear stresses, making sure that this pressure doesn't come to the areas where now an ulcer can happen or a Charcot foot can happen. These can be either removable or non-removable. You have a lot of different types. Usually these are taken care of by our colleagues, the podiatrists, who are very specialized in deciding which type of offloading device the patient can have. So in order to look at where there are areas of pressure, we need to do foot plantar measurement. Foot plantar measurement, the most common way how to do it is we have mats made out of rubber which are connected to a computer. The patient walks on these mats, and we will have an image on the computer which will show us if there are areas of elevated pressure. Nowadays we have computers which are also connected to a 3D printer that can immediately print us a foot sole that we can put in the shoes of the patients, and will start elevating the pressure on those areas. There are different systems obviously available. Offloading is really important, but there are a lot of excuses why we don't use offloading, either from the patient side because they don't want to use it, or also sometimes from us. Think about the different types of offloading devices that you can use. For example, car walkers, you can use air cast pneumatics, but also the total contact cast and other non-removables. However, as we said previously, the importance of offloading is known. It is evidence-based practice. We know that patients who do not use offloading have more risk of amputations, have more risk of infections. But unfortunately, if you look at statistics, it is suggested that only a maximum of 4% of patients who need offloading actually have it. Nowadays, we are blessed to have specialized orthopedic surgeons that can do a surgical intervention of a Charcot foot. This is a highly specialized type of intervention. It needs a specialized surgeon. And if you look, for example, at the IWGTF, it is suggested that the surgery is done if the conservative management of offloading does not work. So in order to summarize the standard of care of our patients, first of all, before we start the stages of standard of care, remember that we are managing the patient holistically. Remember what we talked about in the wound bed preparation. So the first thing that we need to do is do a proper assessment, make sure that the patient has got the support which is needed to manage his disease, making sure that there is good metabolic control, making sure that the patients are receiving proper nutrition and hydration, making sure that they have a support service that will help them in avoiding pressure injuries in the foot which cause the diabetic foot ulcers. Making sure that our patients do go at least once a year to these diabetic foot centers to make sure that the care is being provided as necessary. Remembering that most of these wounds come along in the same way as pressure ulcers, that pressure and shear inside the foot will cause the diabetic foot ulcer. The standard of care which is suggested starts with the offloading devices according to the need of the particular patient, according to the need of the particular ulcer. Ischemic control is of extreme importance. The vascular surgeons in diabetic foot patients are of extreme importance. Make sure that you refer these patients. We do the assessment of their vascular status, and whenever needed, we do revascularization. Prevent as much as possible infection, use those antimicrobial dressings. Whenever needed, use antibiotics. Remember that osteomyelitis is a very big problem in these patients. Debridement when and if needed. Debridement includes removing the callus of the foot when it is causing pressure. Remember again what we talked previously, debridement depends on the circulation. One thing that we are talking a lot about nowadays, which we didn't talk about at all previously, is what type of dressing we are using. In the older days, we used to say it's more important what you take off, pressure offloading, than what you put on the wound. This has changed. If you look at the recent IWGDF guidelines, they actually have a whole section about different types of dressings. They give us suggestions and recommendations on what to use and what not to use. So what I do suggest to you, if you do see patients who are diabetics, make sure that you download at least the summary of the IWGDF guidelines to make sure that we are providing the best care possible for these patients.